One other study that was not heavily featured at ASCO in the main lung sessions was a presentation about a type of mutation that we historically haven't heard that much about, one called STK11 and KEAP, K-E-A-P, two mutations that were found in a large retrospective review of data using chemoimmunotherapy to be found to be associated with a very low chance of responding to immunotherapy-based treatments. And this is not a rare group of patients. This is about a quarter of the patients in these studies have STK11 or KEAP mutations. That said, it's not clear what we would do with this information. We talk about how retrospective data, we should be judicious about drawing conclusions from it. And when we have a treatment that can be very effective, we really are reluctant to withhold that treatment based on data. If it may be a lower chance of benefit, but if it's any chance of benefit, we don't want people to miss that opportunity. That said, it is a potential lead to help us understand more about which patients do and don't respond. Ben, what are your thoughts about the data as you understand? I would have to say it's a pretty complex presentation too. So yeah. It's not that clear to me what the take-home message is, other than this may be a negative prognostic factor, but it's not, to me, something that is actionable in clinic. Your thoughts?
I think that we were part of this data collection and the retrospective analysis. And I think similar to when we're talking about retrospective analysis for early stage 1 lung cancer and the use of adjuvant chemotherapy, it's tough to make treatment decisions based on this data. It is a large data. There is some biological rationale. STK11 and KEAP are tumor suppressors. They do lead to this immune desert in a tumor microenvironment. So there is some traction scientifically. And they essentially showed that patients who got the triplet therapy did worse if you were either STK with or without a KEAP1 versus those that didn't have those. And then if you did have these mutations, you didn't garner a benefit by adding immunotherapy compared to chemotherapy alone. So I think that we will learn more and more about these mutations and whether they truly predict lack of efficacy to immunotherapy in combination with chemotherapy. But I don't think we're there yet. I think we need to learn more. I think we need some prospective data, but certainly there's some biological rationale why they may not, these mutations may predict lack of efficacy. I do not routinely use these mutations to drive my treatment decisions currently as is, but I look forward to more data.
And that was even having been a contributor to the data set. So
yes, yeah.
Charu, do you have any take-home conclusions from this? Where do you think, where are we going in your mind with STK11 and KEAP?
So we were also part of the data collection, and we've done some work internally on STK11 and KRAS, as well as TP53, and how that interaction may play into responses with both chemotherapy and immunotherapy, and also looking at interactions with tumor mutational burden. So I do think that there's something in the story. We all can agree that PD-L1 is a very imperfect biomarker, and wouldn't it be nice to really have a combination of biomarkers to either predict, response to immunotherapy, or perhaps, stratify patients that may not benefit from chemoimmunotherapy or immunotherapy to other approaches and potentially spare these patients the adverse events of immunotherapy. From the presentation, we found that, STK11 and KEAP seemed independent of PD-L1 expression, and there was some thought that tumor mutational burden may also could be used as a combined score to perhaps divide patients in the future in terms of chemo versus chemoimmunotherapy. So I agree with what you and Ben have said. I don't think we're quite there yet, but I can see us really making these decisions in the next 3 to 5 years based on these molecular characteristics. I have personally seen poor responses with immunotherapy. In retrospect, I've gone back and looked at their molecular profile, and I've been surprised that many of them have had STK11. I would just add also that we don't know what the interaction of STK11 is with other drivers or other mutations. For example, STK11 with KRAS or STK11 with TP53 may not behave similarly as just a standalone STK11. So I think more work needs to be done, but this is, I think this is where discovery starts. So I think there's something there.